السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. Dear colleagues, welcome to this webinar that is entitled Circulate, which is going to discuss comprehensive approach to protect non-valvular AF patients. We would like to thank Pfizer for arranging this webinar. I will start by introduction of very few slides just to appreciate the importance of atrial fibrillation in our disease conditions. Now, over the past 3 decades, there has been increase in the incidence and prevalence of AF, and currently approximately 6 million cases has been recorded globally, and contributes to more than 8 million disabilities adjusted life per year. This has been published a few months ago in the Nature Review of Cardiology. The lifetime risk of atrial fibrillation is approximately 33%, with estimates modified by patient-level factors such as age, sex, race, and burden of clinical risk factors such as hypertension, heart failure, coronary artery disease, valvular heart disease, obesity, diabetes, and chronic kidney disease. The increase in atrial fibrillation prevalence can be attributed both to better detection of silent AF alongside increasing age and conditions predisposing to AF. Now, this slide shows the outcome related to AF, death, of course, stroke, left ventricular dysfunction and heart failure, cognitive decline, vascular dementia, depression, impaired quality of life, and hospitalization. All these are conditions associated with substantial morbidity and mortality, resulting in significant burden to patients' social health and health economy. This slide shows briefly the ESC guidelines on the management of atrial fibrillation, which recommended structured characterization and atrial fibrillation better care approach. In short, this is CC to ABC. The first C is related to confirmation and diagnosis of atrial fibrillation, which needs a 12-lead ECG or a rhythm strip showing AF pattern for more than 30 seconds. The characterization of AF is stroke risk, assessment of stroke risk, symptom severity, assessment of severity of AF burden, and substrate specificity. And the rest of the recommended structure is the how to treat AF, the ABC pathway. The A is for anticoagulation to avoid stroke. You know all that when we assess for anticoagulation, we need to identify the low risk patients, how to offer a stroke prevention through the CHAD-A2 VASC score, and to assess bleeding risk by HAS-BLED to be able to choose the perfect anticoagulation management of the case. Then B is synonymous to better symptom control, either using antiarrhythmic drugs, cardioversion, ablation, and all that is to optimize rate control. Finally, the comorbid conditions, how to control the comorbid conditions, such as obesity, regular exercise, and the comorbid conditions are a lot, like hypertension, like diabetes, and definitely, of course, chronic kidney disease. Now, I'll just focus here on the diagnosis of AF and screen also of AF because of the widespread of tools that we have nowadays. So definitely, of course, as I mentioned, that a standard 12-lead ECG recording or a single lead ECG tracing of more than 30 seconds showing heart rhythm with no discernible repeating P waves means atrial fibrillation is the criteria for diagnosis atrial fibrillation. Now, there is a term of what's called opportunistic screening for atrial fibrillation by pulse taking or ECG rhythm strips is recommended in patients above 65 years of age. How to do that? As this is a published position paper by ERA in 2022, how to use digital device to detect management arrhythmia. And as you see, we have a lot of tools nowadays, the watch, the single lead monitoring, the detection with implantable devices such as CRT, IDC, and all these are nowadays available. Even we have the patch that can record heart rhythm for up to 14 days. Now, this slide is the last slide and shows the how the impact of adherence to the ABC pathway in patients with EF and the outcomes. Unfortunately, we can see here that the prevalence of adherence is only 21% out of a systematic review and meta-analysis of almost 285 patients. And those who were adherent to the ABC pathway showed significant reduction of all-cause mortality by almost 58%, as well as significant reduction in cardiovascular death, significant reduction in ischemic stroke, and with an incidence of major bleeding at a level of 31. That also was associated with better symptoms management. Now, I can now shift to the first presenter, Dr. Salah Al-Badri, consultant in cardiology department, Heart Hospital, Qatar, and he's going to present for us the real-world data in relation to NVAF. Please, Dr. Salah.
Thank you, Dr. Saeed. Can you see my slides?
Yes.
Assalamu alaikum wa rahmatullah. My objective today, I'll walk you through these objectives, assessing the risk encountered by patient with non-valvular atrial fibrillation. We'll review randomized controlled trials evidence comparing NOACs and warfarin, and we'll analyze real-world data assessing the efficacy and safety of novel oral anticoagulants. The introduction by Dr. Saeed was very useful and important to highlight the importance of atrial fibrillation as, I believe, a malignant disease. 1 in 3 patients in Europe and US will develop atrial fibrillation. 5-fold increase in risk of stroke in atrial fibrillation versus those without atrial fibrillation. And the atrial fibrillation related ischemic stroke fatal by 2-folds if you compare it with non-atrial fibrillation stroke. And unfortunately, 1 in 4 patients with atrial fibrillation related stroke will die within 30 days. These are a summary of extensive outcomes or poor outcomes facing atrial fibrillation patient. Mortality, 1.5 to 3.5-fold increase in mortality the excess in mortality related to complications like heart failure and comorbidities and stroke. The stroke itself, we have 20 to 30% of all ischemic stroke related to atrial fibrillation. And we have a 10% of what we classify as cryptogenic stroke is related to undiagnosed atrial fibrillation. The mechanism usually cardioembolic mainly, but we can get also a vascular atheroma. 20 to 30% of patients with atrial fibrillation will have LV dysfunction and heart failure. This is mainly because of tachycardia-induced cardiomyopathy and functional valvular regurgitations. This is not limited to the heart. We can get cognitive decline, vascular dementia. This is irrespective of patient having a stroke or no. This is a brain white matter lesion and inflammation, hypoperfusion and microembolisms. Depression is common as well. 16 to 20% of patients with atrial fibrillation will have depression and decreased quality of life. Will have impaired quality of life. More than 60% of patients will have impaired quality of life measures due to psychological function dysfunctions and distressed personality type. And we have very frequent hospitalization for patients with atrial fibrillation, 10 to 40% annual hospitalization due to either treatment of atrial fibrillation, heart failure decompensation, and other complications related to medications. So the atrial fibrillation is associated with increased risk of severe stroke. 33% of ischemic strokes are related to atrial fibrillation, and more than 80% of cardioembolic strokes are related to atrial fibrillation. Atrial fibrillation may play a role in 10% of cryptogenic strokes. The atrial fibrillation related stroke cause larger area of brain infarction, greater disability and mortality if you compare it with other stroke etiologies. The good thing that it is largely preventable, and oral anticoagulant reduce the risk of stroke by more than 64% and mortality by more than 25% versus placebo. And it is a balance between, if you think of complication will not treat, the risk of intracranial hemorrhage is quite low in favor of the benefit of getting 64% prevention of stroke and 26% risk of reduction in the mortality. This is well known to you, the SHAD-VAS score and Hasbled score, they remain the same. They are very important. The SHAD-VAS score will determine for non-valvular atrial fibrillation. We give the indication to start medications, more than 2 or more for males and 3 or more for females. The Hasbled score is important. If it's more than 3, it is high, but it should not be a reason to deny treatment. And we have to look carefully to the modifiable bleeding risk factors. We have to adjust them. We have things we cannot do anything for, like age or patient with like malignancy or diabetes, other non-modifier risk factors. But the SHAD-VAS score, the Hasbled score, the blood pressure more than 160 as a request to be a factor. If you control blood pressure, then we take off this risk factor, and then also we see if the patient should be in aspirin or non-steroidal. If not necessary, it should be removed from his treatment. Patient should abstain from alcohol, and we should advise against competitive sports and occupations which give him the risk of fall and trauma. And we have to look for time therapeutic ratio more than 70. So things will be okay for the patient or prevent. Now, this is the European Society of Cardiology 2021 algorithm to treat a patient with non-valvular atrial fibrillation. Patient with valvular should be excluded from, DOAC therapy. Prostatic valve or moderate severe mitral stenosis. If yes, then vitamin K antagonist alone, no NOAC. Now, if the patient has non-valvular atrial fibrillation, we estimate SHAD-VAS score. And if it is 0 or 1, no antithrombotic, and please no aspirin as well. So there is no rule for aspirin or antithrombotic, any antithrombotic, if the male is 0 or female 1. Now, if it is more than that, we address the modifiable as we discussed, bleeding risk factors, and calculate the HAS-PLED score and address modifiable bleeding risk factor, and we'll look to the score now. If it is for male 1 or for female 2, this is should be considered like class 2A, B. And if it is more than 2 or female more than 3, as you know, then oral anticoagulant is recommended, preferably NOAC. Now, if the patient choose vitamin K antagonist, the TTR should be at least 70% or more. Now, in some situation where patient cannot afford, or we have like in community where not everyone can afford NOAC, and we need to like select which patient should go with warfarin or NOAC. This is if you are SCORE fan. This is SCORE since 2013, same TTR score, and involve these definitions. S for sex, female, age more than less than 60, medical history, comorbidities, hypertension, diabetes, etc. And if the patient has a treatment such as amiodarone or for rhythm control, or if he is a smoker, or if he is non-white, and if the patient has more than 2 or equal to 2 or more, then this patient would not do well with vitamin K. So he should go for NOAC. Let us just look to the evidence between NOAC and warfarin from the randomized controlled trials side. And as you know, we have 4 medications of 4 trials, and we'll start with Aristotle. Aristotle is for apixaban. It was a large randomized double-blind trial in patients with atrial fibrillation and at least 1 additional risk factor for stroke. Around 18,000 plus patients, and the dose was 5 milligram BID. And if it is 2.5, then we have the criteria like age more than 80, or weight less than 60, or creatinine more than or equal to 1.5 milligram. And the baseline was age 70, median age. SHAD-VAS score score was 2.1, and TTR 62.2. And it was a successful trial. They met their primary efficacy endpoint in terms of prevention of stroke or systemic embolization. There was like 21% relative risk reduction, statistically significant for superiority. And the other primary safety endpoint was major bleeding. Again, it was statistically significant for relative risk reduction of 31%. And p-value was very low. Now, in key secondary outcomes, the intracranial bleeding or hemorrhage was in favor of apixaban. GI also was less, GI bleeding. And so mostly in the left side of the one. So this is the Aristotle. Rely for, for dabigatran was for a non-valvular atrial fibrillation with at least one risk factor for stroke. So around 12,000 patients or more than that. I think it's 18,000 again. They use two arms, actually, three arms, warfarin and dabigatran 110 and dabigatran 150 milligram twice BID. And the mean age is almost the same as the previous trial. SHATS2 score was 2.1 and TTR was 64. So because it's three arms, if the warfarin compared to dabigatran as a first efficacy endpoint, which is a stroke or systemic embolization, it was not significant between the two, between warfarin and dabigatran. But it was significant if you use the 150 milligram dose by relative risk reduction 35% with a statistically significant p-value. The safety was safe if we, or between the 110 milligram and warfarin, but it was non-significant if you use 150 milligram dose. If you can observe here in the key secondary outcomes, the 150 milligram has more GI bleeding than warfarin. For ROCKET, a double-blind study also for rivaroxaban, patient with at moderate to high risk for stroke, the median age almost the same. SHAD score was higher here for among the other trials, 3.5. And the mean TTR was 55. It compared warfarin with 20 milligram rivaroxaban dose, and it's 15 milligram of the GFR 3049. So the primary efficacy endpoint, the rivaroxaban was non-inferior, but at the same time, it was not superior to warfarin. The same for safety endpoints. It was not superior to, if you compare it to warfarin. Again, the same observation here, GI bleeding was in favor of warfarin. For edoxaban, they compare both warfarin and edoxaban, the age and SHAD score almost same as other trials, TTR as well. And again, in the form of primary efficacy endpoint, it was non-inferior to warfarin, but was not superior. And it was like in the primary safety endpoint, it was like 20% relative risk reduction with a significant p-value in favor of edoxaban. Again, here the 60 milligram dose of edoxaban was more GI bleeding. Okay, this is a famous meta-analysis for all trials. And the bottom line here, if you combined everything, so it will be in favor of NVAF. Of course, we have, as we discussed, some variability between the NVAFs. Like in here, we have as a reduction of stroke or systemic embolization, we have the dabigatran 150 and we have the apixaban 5 milligram BID. These two medications were superior to warfarin. Others were non-inferior. Again, here for the major bleeding, we have apixaban 5 milligram BID or edoxaban 60 milligram OD was superior than and better than warfarin. Others were like non-inferior. And the meta-analysis saying overall major bleeding in favor of NVAFs. Here the same information, but with different dosage. Now, the 10 milligram, this is regarding major GI bleeding. The 10 milligram dabigatran, it was along with apixaban. It was safer than warfarin, but the rivaroxaban and the dabigatran 150 were they were the same most. So the dabigatran 150 and rivaroxaban demonstrates a significant increase in GI bleeding compared to warfarin. Okay, this was like for the controlled randomized trials. What about the real world data? You know, the randomized controlled trial are the gold standard to evaluate treatment outcomes, providing reliable information on treatment efficacy. They test therapeutic hypothesis under optimal conditions with like selection and without confounding factors. But in real life studies, we inform about effectiveness of treatment in the daily routine use without selection. And if you just quickly compare them, the randomized controlled trials, they have like very strict design, analysis method, randomization, blinding, control. These are all advantages. Disadvantage, they are very selected population, monitored, and might have monitoring bias and setting, and a lot of ethical restrictions. It is inappropriate to evaluate all adverse effects, and usually short duration. For real-world studies, non-selected population, realistic therapy adherence, logistic and ethical feasibility, useful to detect rare or late onset adverse events, and it is usually long duration with large and massive number of patients. The disadvantage, lack of selection, so brings confounding factors. Confounding factors, I'll give you example now. If a patient, for example, has he's alcoholic and he had CA lung, there is no direct causal reason to have cancer because of alcohol, but this patient will be like smoker. This is a confounding factor. This cannot be controlled in real world. So we'll say alcohol causing CA lung, but the confounding factor is smoking. And the other problem is absence of randomization and blinding. We have two things we have to know. We have real-world data. This is the collection of data of patient health status, and we have the evidence analysis of the data called real-world evidence. And we'll give you example here with very large trial, real-world trial. This trial called Aristophanes. You see here more than 180 million, 56% of US population, and around 500,000 patients using apixaban, dabigatran, rivaroxaban, or warfarin. And they use a propensity matched data set to treat the bias in real-world data, and they matched them either to warfarin or NVAF to NVAF, and see the number of patients. You cannot get this and control the randomized trials. Numbers with huge, massive numbers, you know, to give a comment. And just in short, this is the efficacy of NVAF and versus NVAF, and this is the result of from this large real-world data. Apixaban versus dabigatran, 28% relative risk reduction in form of stroke and systemic embolization, major bleeding 22%, and GI bleeding 34%. Again, apixaban versus rivaroxaban in favor of apixaban, 20%, stroke and systemic embolization, and major bleeding 45%, and GI bleeding 52%. So the apixaban confers favorable effect versus warfarin as compared to other NVAFs versus warfarin in terms of stroke and systemic embolization and major bleeding event in patient with atrial fibrillation. in the same database, in the same real-world data. The intracranial hemorrhage was in favor of all DOACs compared to warfarin. And if you compare them together, apixaban and dabigatran, no difference. But if you compare dabigatran and rivaroxaban, in favor of the first, that means dabigatran. And if you compare apixaban to rivaroxaban, in favor of first, that means apixaban. So this is another large population, and just in short, in this huge number of patients with very elderly patients, like more than 75 age, the apixaban had 55 and 61% lower risk of associated with GI bleeding in the very elderly versus dabigatran and the rivaroxaban respectively. For overall age, it was again in favor of apixaban by 61 and 67%. In this study as well, apixaban had a favorable major GI bleeding safety profile, while rivaroxaban and dabigatran were the least safe. 89% apixaban and 23 and 83% for rivaroxaban and dabigatran. What about Asian population? This is a study again showing superiority of apixaban compared to warfarin. This is going with even controlled randomized trial, stroke prevention and systemic embolization, 45% versus warfarin, 55% intracranial bleeding compared to warfarin, relative risk reduction, and 59% for GI bleeding and major bleeding. So unlike standard dose of NOAC, apixaban was associated with a lower risk among others in terms of major bleeding versus warfarin. So we have now very comprehensive, robust real-world data and evidence, and also randomized trials, get us understand the NOACs more, and we have them integrated in the guidelines. And this is one example of the guidelines using the controlled trials and real-world data. AHA, ACC, HRS 2019 focus update recommend SHADVA score to assess stroke risk. NOAC, including oral anticoagulant, including warfarin and the DOAC. If SHADVA score is more than 2 for men and more than 3 for women, this is like agreement between all guidelines. And they here insist and recommend to recommend DOAC over warfarin unless the patient has mechanical valves. And they recommend to evaluate renal function and hepatic function before initiating DOAC. And here stated that many DOAC, except apixaban, have limitation use in patients with renal impairment. This will we'll learn more in the next presentation by Dr. Adil. Now, this is another guideline, 2021 AHRA practical guideline. There are various factors to consider when initiating anticoagulation. NOAC are preferred again over in vitamin K antagonists, and all NOAC eligible atrial fibrillation patient. And when start NOAC, knowledge of the kidney function is important. They are all agreeing with this. Shared decision should be between patient and physicians and patient. This is very important because the compliance, issue. Some patient will not take medications, if you give them like twice, some will be very restrictive, and if you give it 4 or 5 times. So we have to have like shared decision before prescribing anything. Obtain a baseline hematological profile referring reference during follow-up, further follow-up. Bleeding risk is not as itself a reason to deny oral anticoagulation. Again, also frailty, cognitive decline, or risk of falling should not be reason to deny and it should be like assist patient to patient. This is from 2022 European Society of Cardiology guidelines, and also the HRA 2021. We have two doses, the standard dose and lower dose and reduced dose, so three definitions. Standard dose is 150 milligram for BID for the dabigatran, rivaroxaban 20 milligram, apixaban 5 milligram BID, and edoxaban 60 milligram OD. The lower dose is 110 milligram for the dabigatran. Reduced dose is 15 milligram for rivaroxaban and apixaban 12.5 BID, and edoxaban 30 milligram OD. So for those criteria, dabigatran 110 milligram BID in patient if he is very elderly, more than 180, or if he using other medications like verapamil, or he has increased bleeding risk. For rivaroxaban, only one condition, for 15 milligram, creatinine 15 to 49. For apixaban, if you use 2.5, you have to have at least 2 of 3 criteria: age more than 80, or body weight less than 60, or serum creatinine more than 1.5 milligram or 133 micromole. And edoxaban dose is 30 milligram according to the creatinine of 15, creatinine clearance 15 to 50, or again the body weight less than 60, or if he is taking some medications. Always we have to advocate the standard dose when it's possible. Now, this is from the European Society of Cardiology 2016 guidelines, saying that in patients at high risk of GI bleeding, vitamin K or another NOAC preparation should be preferred over dabigatran 150 milligram twice daily and rivaroxaban 20 milligram once daily. So the patient at high risk of GI bleeding. Hey, they didn't name any medications, only any specific, but in this expert consensus or recommendation in European Heart Journal is saying if you have a high risk of GI bleeding, for patient with a high risk of GI bleeding, apixaban 5 milligram twice daily or dabigatran 110 milligram twice daily may be used. And second choice will be dabigatran 150 milligram or edoxaban 60 milligram or rivaroxaban 20 milligram once daily. And this is my conclusion. Evidence from 4 major studies and meta-analysis showed a lower incidence of stroke and intracranial hemorrhage with a trend toward lower rate of major bleeding when using NOACs compared to vitamin K antagonists. Real-world evidence consistently supports controlled trial results and has been incorporated in guidelines over the last decade. We have to achieve a balance between effectiveness and safety, can be also a challenging risk. Apixaban strikes the perfect balance between efficacy and safety for most patients. And thank you for your attention.
Thank you very much, Dr. Salah, for this comprehensive overview on the atrial fibrillation and its complications and management, and the comparison between the available NOACs versus the vitamin K antagonist. And we will defer the discussion after the second presentation. The second presentation is Dr. Adel Khalifa, who is a consultant cardiologist and interventional cardiac electrophysiologist, head of electrophysiology department in Mohammed bin Khalifa Cardiac Center in Bahrain. He's an expert in the field of arrhythmias, and in particular, he has been giving a lot of presentations on atrial fibrillation from different points of view and its management. But today he is going to present for us a very important topic, which is NOACs in end-stage renal disease, which is not uncommon and common comorbid condition in with AF. Please, Dr. Adel, tafadhal.
Thank you, Professor Saeed, for the kind introduction. Good evening, ladies and gentlemen. I would like, first of all, to thank the organizers for their kind invitation. It's indeed my great pleasure and honor to speak to you today in this webinar. And I was given the task to talk about the NOACs from end-stage renal disease perspective. And before I would start, I would like to share with you all my disclosures. And as you can see, I am involved in all the pharmaceutical companies dealing with NOACs through different roles. The outline of the presentation, I will start with introduction, followed by classification of chronic kidney disease. Then I will be talking about warfarin and NOACs in chronic kidney disease, dosing of these drugs, and finally some highlights of the guidelines. I realize that I have probably 65 slides, so my apologies if I skip some of them just to accommodate the time allocated for myself. So population-based studies have shown that atrial fibrillation is quite common in patients with a chronic kidney disease. Some studies have shown that patients with chronic kidney disease not on dialysis, they have a 20% prevalent rate of atrial fibrillation, while in patients with dialysis, 33% of these patients, they will have atrial fibrillation. And it seems that what we learned in the last decade is that as the renal function declines, there is increase in the prevalence of atrial fibrillation. The stroke and the bleeding rates also are increased, but at the same time, the evidence of antithrombotic therapy will be much scarce. Renal impairment and cardiovascular diseases share not only common risk factors, but also can lead to progression of these conditions, which eventually leads to stroke, ischemia, acute kidney injury, heart failure, which collectively succumb into death. If you ask me how risk factors predispose to AF, and I'm not going to spend too much time on this slide, but common risk factors like hypertension, for example, leads to left ventricular hypertrophy, which is, one of the causes of myocardial fibrosis, which by itself can lead to atrial fibrillation. Heart failure is an important substrate for the development of AF because of atrial dilatation and electromechanical remodeling. Vascular disease, diabetes mellitus, and electrolyte imbalance are all common factors that predispose to atrial fibrillation through different mechanisms. And we should not really forget autonomic imbalance in the form of increased sympathetic activity, which can lead also to atrial fibrillation. Now, patients with chronic kidney disease, they are at risk of thrombosis because CKD by itself fulfills the criteria of Virchow's triad. There is abnormal blood viscosity because of the release of some mediators, including prothrombin 1 and 2, plasma tissue factors, and increase in D-dimers. There are abnormal blood flow related to atrial stenting and atrial dilatation, and also there is abnormality in the vessel wall due to myocyte hypertrophy and fibroelastosis. All in all these interrelated factors predispose patients of a chronic kidney disease with thrombosis. On the other side of the story, also patients with CKD, they are at risk of bleeding because CKD leads to alteration in the platelet synthesis and composition and activation, also leads to dysfunction in the platelets and reduced platelet aggregation. So as you realize that the combination of AF and end-stage renal disease associated with much higher mortality. One reason, because of the thromboembolic complications, and we have now good evidence to suggest that patients with a chronic kidney disease, they are twice as likely to suffer from thromboembolic complications compared to those without CKD. another study by Chow, he mentioned that patients with end-stage renal disease, they have 12% chances of experiencing ischemic stroke compared to similar age without end-stage renal disease. And a good percentage or a good number to remember from this slide is that stroke risk increases by 7% for every 10 ml reduction in the GFR below 10 ml. And finally, there is an inverse relationship between GFR and stroke mortality. So as the GFR is reduced, the stroke mortality increases. Now, the second reason why the combination of AF and end-stage renal disease result in high mortality is because of hemorrhagic complications. And what we know is that both forms of dialysis, either peritoneal or intravascular, carry 12-fold risk of GI bleeding. And based on 300,000 healthcare records from the Swedish registry, it has been shown that the risk of any type of bleeding was 30.5% in renal failure versus 14.1% without renal failure. And if we focus on the types of bleeding in this group of patients, we can see that it can range from mild nuisance bleeding like epistaxis, ecchymosis, purpura, petechiae, to a fulminant bleeding in the form of GI bleeding, subedural hematoma, and hemarthrosis. Now, you have to keep in mind that there are challenges in the management of AF patients with CKD. One of the challenges is how to quantify the renal function in this group of patients. Now, there are three popular equations that we use to estimate renal function. One of them is the Cockcroft-Gault formula. The second one is the MDRD formula. And finally, the CKD EPI formula. Now, if you ask nephrologists, they prefer to use CKD EPI formula to estimate GFR, but there are no consensus as to use this specific formula across all patient population. And also, you have to keep in mind that in phase 3 clinical trial, including the RELY and the ROCKET and the Aristotle and other clinical trials, they used the Cockcroft-Gault formula to estimate creatinine clearance. And also, you have to keep in mind that creatinine clearance or GFR calculated through this formula can yield striking differences. So they are not equal, and you have to take into consideration the exact calculation of renal function. So this is one of the challenges that you have to keep in mind when you deal with patients with AF and CKD. The other challenge that face physicians in a clinical practice is how to apply the bleeding and the clotting scoring system. Now, as you know, there are a number of stroke risk scores and bleeding risk scores, and they are actually validated across a wide range of population, but their transferability to patients with a chronic kidney disease is very limited. Let us focus on the stroke risk scores, for example. The ATRIA has a single factor inflection point in patients with a GFR of less than 40. The R2 CHADS, which we don't really use, but you have 2 points for creatinine clearance or GFR less than 60. But none of these risk scores categorize patients with a chronic kidney disease based on grades. Also, some of these risk scores are not really validated with a GFR is less than 30. Finally, we use the CHAD-VASC score, which is the popular risk score for the assessment of a stroke, and it does not have any renal parameter, for calculation. If we switch to the bleeding risk scores, similar to the stroke risk scores, there are no clear categorization of renal impairment in any of these, despite the fact that we are using the Hasbled score, which has a renal impairment, but it is a single point without going through the grades of renal impairment. So these are also challenges when you deal with patients with CKD. Now, warfarin, we know that warfarin works very well in patients with AF. It reduces the risk of stroke by 65 to 70%. Also, it reduces mortality by roughly 25%. But also you have to keep in mind, and this is something we discovered lately, that warfarin use in patients with hemodialysis results in abnormal calcium metabolism, leading to calciflexes, which manifest as a tender skin lesions due to thrombosis and calcifications of the skin arteries. Also, warfarin is related to anticoagulation-related nephropathy because of glomerular hemorrhage and renal tubular obstruction, and we will talk about that in subsequent slides. This is actually a very interesting paper, came from Ontario and Quebec, Canada, where they look at all admissions, primary and secondary, of patients with AF over a span of 9 years, and they are stratified based on whether they receive dialysis or they don't receive dialysis. And as you can see, there are 1,600 plus in the group of the dialysis and 200,000 plus in patients in the non-dialysis group. And as you can see, that using warfarin in the dialysis patient did not reduce a stroke. And as a matter of fact, there is a 44% increase in major bleeding in patients on warfarin while on dialysis. This is actually a slide presented by Dr. Salah. This is one of the landmark trials or meta-analysis of the NOACs, and one of the most important papers ever written in the NOACs. And as you can see, if you look at the pooled data of all NOACs, we can see that the NOACs associated with 20% relative risk reduction of stroke and systemic embolism. When it comes to the secondary efficacy and safety outcome, we can see that ischemic stroke were more or less the same between warfarin and NOACs, while hemorrhagic stroke and intracranial hemorrhage was significantly lower in the group randomized to NOACs versus warfarin, with a relative risk reduction of almost 50%, and that was highly significant. When it comes to major bleeding, we can see that all in all, as a pooled drugs, there is a 20% relative risk reduction of major bleeding compared to warfarin. Now, the new oral anticoagulation, they have a different pharmacokinetics, but what is important from this slide is to focus on the fact that the renal excretion of these drugs are quite different. It is high for dabigatran at 80%, and for rivaroxaban, it is like 35%, abexaban 25%, and for edoxaban, it is 50%. Likewise, if you look at the patient demographic in these clinical trials, they are also different. We know that in Rocket AF, patients included were at higher risk compared to other phase 3 clinical trials. You can see the mean CHADS score was a 3.5 compared to, for example, 2.1 in the RELY and the Aristotle. More patients have heart failure and hypertension in the Rocket AF. And if you look at the percentage of patients with moderate renal impairment, you can see that there are 21% in the Rocket AF. They had moderate renal impairment versus 19 in the RELY and ENGAGE and 15 in Aristotle. So you have to keep this in mind when you interpret these results. And also what we found that the prevalence of AF in patients with end-stage renal disease in one of the series can range from 11 to 13, and there is 1.4-fold increase in the risk of stroke in patients with AF and end-stage renal disease, and 2-fold increase in the bleeding risk. Similarly, and if we focus on Aristotle, and you've seen this graph earlier, is that as the renal function decline, the stroke rate increases. And you can clearly make a conclusion from this table that the annualized stroke rate was twice as high in patients with a GFR less than 50 compared to GFR more than 80. Similarly, the risk of major bleeding was almost 3 times in those with a GFR less than 50 compared to those with a normal GFR. Now, it's important to classify the CKD, and again, I'm not going into details on this, but renal function can be classified into 5 stages, from normal, mild, mild to moderate, moderate to severe, and grade 4, which is severe renal impairment with a GFR between 15 to 29, and grade 5, this is the the end stage renal disease, where patients, they are typically on dialysis with a GFR less than 15. Now, what do we have in terms of data on warfarin and CKD? In patients with AF and CKD, renal function declines faster in those with vitamin K antagonists compared to those without exposure to vitamin K antagonists. And at 5 years, the difference is striking and highly significant. Also, it seems that as we use warfarin over an extended period of time, the chances of arterial calcification become more and more. And at 5 years, the difference between warfarin and control was highly significant. This is a very important slide that I would like to spend some time. We know that vitamin K antagonist promotes medial and intimal calcification. Our body has a protective mechanism through a protein called matrix G1 protein, which basically inhibit vessel calcification. But the tricky part is that for the MGP to inhibit vessel calcification, it has to be carboxylated. And the carboxylation is carried out by vitamin K factors. That is why if you give vitamin K antagonist, you inhibit the vitamin K dependent factors, so matrix G1 protein will never be carboxylated, and that's why the calcification will be enhanced. And the medial calcification is highly prevalent in patients with CKD. Similarly, it seems that factor 2 and factor 10 leads to activation of protease activated receptor, or what we call them BAR. And BAR is well known to have a pro-inflammatory and a pro-fibrotic features. That is why NOACs, which inhibit factor 10 and factor 2, reduce the signal through BAR and subsequently result in inhibition of proliferation, remodeling, and oxidative stress, and that is why it can protect from vessel calcification. So while warfarin can increase vessel calcification, we have some evidence that NOACs protect against vessel calcification. And there are a number of papers in the literature talking about warfarin-related nephropathy, which is a newly recognized complication of an old drug. So we use warfarin all the time in patients with a chronic kidney disease, and we did not ask ourselves, do we have evidence for that? Actually, the answer is we don't have any evidence based on randomized clinical trials on the use of warfarin in AF with the chronic kidney disease. And all the evidence that we have is based on observational studies. Also, and what is really interesting is that as the GFR decreases, the time in the therapeutic range also increases, so it subjects patients to higher risk of stroke. This is basically the meta-analysis which address the question, what is the role of warfarin in preventing ischemic stroke in patients with AF and end-stage renal disease? This meta-analysis included 15 studies, more than 47,000, and 10,000 patients were taking warfarin. The conclusion from this study, warfarin was associated with no change in the incidence of ischemic stroke. So it was not a protective against ischemic stroke. At the same time, it was associated with higher risk of bleeding. How about actually NOACs in CKD? Let us start with rivaroxaban. This is one of the important studies which was published in JACC 5 years ago by Yao, who compared the effect of NOACs, specifically 3 NOACs, apixaban, dabigatran, and rivaroxaban, with warfarin against 4 renal parameters: 30% or more decline in GFR, this is 1, doubling of the serum creatinine, 2, development of acute kidney injury, 3, and the development of acute or kidney failure. So this study have shown that all in all, NOACs were associated with roughly 23% relative risk reduction of 30% or more decline in the GFR compared to warfarin. NOACs associated with roughly 40% reduction in the doubling of the serum creatinine versus warfarin. And also there is like 32% relative risk reduction of acute kidney injury compared to warfarin. And sub-analysis from this study have shown that rivaroxaban was actually or have more favorable outcome in these renal, specifically in these renal outcomes compared to the other NOACs. Another a study by Ponemier, which is the reloaded study, and which was designed to compare the risk of renal function worsening with NOACs versus phenobrucamone, which is a vitamin K antagonist used in Germany and in other countries in Europe, with an endpoint, the development of acute kidney injury, end-stage disease, or dialysis. Now, this slide, you can see on the left side, comparison between rivaroxaban versus phenobrucamone, and on the right side, comparison between apixaban versus phenobrucamone. And you can see that both drugs associated with significant reduction in the development of end-stage renal disease or a chronic kidney disease requiring dialysis. At the same time, rivaroxaban and apixaban were associated also with overall reduction in the development of acute kidney injury. It was significant with rivaroxaban, and there was a trend, but it did not meet statistical significance with apixaban. Another study looking at rivaroxaban in patients with heart failure, and this is also based on MarketScan database. In this cohort of patients, they collected patients with AF. They are taking either rivaroxaban or warfarin, and they have end-stage renal disease. This study have shown that there was no difference between rivaroxaban and warfarin when it comes to stroke and systemic embolism, or you can say that there is a trend, but it was not statistically significant. But there was a statistical significant reduction in major bleeding in favor of rivaroxaban compared to warfarin, with a hazard ratio of 0.68. How about apixaban in patients with AF and renal impairment? The first study basically came from Siontis, was published 5 years ago. Again, this is MarketScan database. They used all AF patients with end-stage renal disease requiring dialysis, and these are stratified by 2 dosages, either those who received 5 milligrams apixaban or those who received 2.5 milligrams apixaban. And as you clearly see, that the 5 milligrams of apixaban associated with significant reduction in the stroke and systemic embolism, there is a significant reduction in major bleed and in mortality. Another study that I will not really spend too much time on this because I think I'm running out of time is the renal AF. The renal AF was designed to recruit 760 patients, and you're supposed to randomize patients with AF and CHA2DS2-VASc score of 2 or more, and they have to be on hemodialysis to either apixaban or warfarin. And the primary outcome was major and clinically relevant non-major bleeding. Unfortunately, and this is actually carried out in 40 centers in the United States, unfortunately, the study was prematurely terminated because of slow recruitment, and the study analyzed only 154 participants, but I guess it was not really powered to determine the safety of either drug in patients with renal failure. There was a study, looking at the comparison between rivaroxaban versus apixaban in patients on dialysis. So this study, again, was published 3 years ago to evaluate the effectiveness and safety of rivaroxaban versus apixaban in patients with AF and end-stage renal disease and or undergoing dialysis. And as you can clearly see, there was no difference between rivaroxaban or apixaban when it comes to efficacy, i.e. stroke and systemic embolism, or safety, i.e. major bleeding. So both of them, they were the same. There was actually a pharmacokinetic study done in apixaban in hemodialysis patient, and this is what has led the FDA to approve apixaban in patients in hemodialysis. It's not a randomized clinical trials, it is just pharmacokinetic study. And what they found in this study, that apixaban 2.5 milligrams twice daily in patients on hemodialysis resulted in a drug exposure comparable to that of a standard dose in patients with a preserved renal function. The Excedia AFNet study, probably this is the latest study, which was again published 6 months ago. It was done in 39 centers in Germany, 97 patients with end-stage renal disease randomized to receive either apixaban 2.5 twice daily or phenobrucamon. And the conclusion from this study that there was no significant difference in the safety or efficacy between apixaban or vitamin K antagonist in this group. Dosing of NOACs, we've seen it. Dr. Salah had highlighted the dosing very well. If we look at, and this is actually the last 3 slides of my presentation, if we look at the guidelines, and I will just focus on stage 4 and stage 5 renal dysfunction, and I am actually showing here 5 of the guidelines: the AHA-ACC HRS guidelines, the CHEST guidelines, the KDIGO, the ERA, and the European Society of Cardiology. So in this group of patients, stage 4, warfarin can be used. Dabigatran was recommended at 75 milligrams in this group of patients, mainly the CHEST guidelines and the AHA-ACC guidelines, because these are American guidelines, and the 75 milligrams is approved only in the US. I don't think it's available or approved anywhere else. The European, they did not recommend using dabigatran in this category of renal failure. Apixaban, as you can see, it can be used either 5 or 2.5. Similarly, rivaroxaban, and in this group of patients, they were recommended to use 15 milligrams. In patients actually with a chronic kidney disease requiring dialysis, again, the AHA-ACC HRS guidelines and the CHEST, they recommend actually warfarin, keeping an INR between 2 and 3. The European, they did not specifically discuss this issue in their guidelines. Dabigatran was not recommended by any of the guidelines in patients with chronic kidney disease on dialysis. Apixaban, again, you can see some guidelines recommend 5 or 2.5 depending on the risk of bleeding. The CHEST guidelines, they recommended 5 milligrams twice daily. Rivaroxaban was not recommended. to be used in this group of patients, except by the KDIGO, where they said that probably 15 milligrams might be beneficial. But again, if you look at, this is the last slide before my conclusion, if you look at the European and the FDA recommendation now, again, the recommendation of apixaban and rivaroxaban is not based on any randomized clinical trials. It was purely based on pharmacokinetics. And if you look at dialysis, the FDA recommend 5 milligrams of apixaban in patients on dialysis, while the European, it's contraindicated. When it comes to rivaroxaban, they mentioned that there are limited data, but then again, they potentially recommend the smaller dose, 15 milligrams of rivaroxaban in patients with dialysis, while again, the European are contraindicated. Now, this came with a message that although the FDA has mentioned this, it did not endorse the indication, and they wrote that it is not known whether these concentration will lead to similar stroke reduction and bleeding risk in patients with end-stage renal disease on dialysis, as was seen in the Rocket AF or Aristotle. So, ladies and gentlemen, Mr. Chairman, my conclusion. Clinical trials and real-world clinical data from the non-CKD setting cannot be reliably and safely extrapolated into clinical practice for patients with significant dialysis or chronic kidney disease. Initiating oral anticoagulation in CKD patient is contentious due to their increased propensity for both thrombosis and bleeding. Conventional scoring system for estimating bleeding and clotting risk factors are not validated in patients with CKD and cannot be relied upon alone for a clinical decision-making. CKD patients receiving vitamin K antagonists are susceptible to vascular calcification and anticoagulation-related nephropathy, so you have to be very careful with that. And finally, very limited data on the use of NOACs in stage 4 and 5 dialysis patients. Nevertheless, FDA, but not the EMA, recommends using apixaban and rivaroxaban in this category purely based on pharmacokinetic data and not on randomized clinical trials. And thank you very much.
Thank you very much, Dr. Adel, for this elegant, comprehensive presentation. Actually, I personally benefited from the recent data and the comparisons between the NOACs and the vitamin K in the settings of end-stage renal disease. You touched on the confusing problems in the assessment of renal function and the assessment of the risk scores and the differences between the risk scores. So that was a very useful presentation. Now I have some questions that you answered already some of them. Also, Dr. Salah answered some of them, but I will highlight some of these questions. Okay. One question is probably related to the presentation of Dr. Salah. Is is there any data on the incidence and the prevalence of AF in our region?
Oh,
I think our region, he means the Gulf area.
Yeah, this is good. The question I don't know whether there is any registry now for atrial fibrillation, but maybe it will be the same worldwide. It's according to the age. Below 60 will be 1 to 2%. 60 and above will be like 2-3, and above 80 will be higher, like 10%. But I'm not aware. I don't know, Dr. Adel. Do we have any such prevalence available or any data?
Yeah, the data are very limited, really, in terms of a well-designed study. But we have the Gulf Safe, which was published almost a decade ago. And then we have also more recent data in the Middle East. I don't know how accurate is the number, but this is published, and they estimate that the prevalence of AF in our Middle East is roughly between 35 to 74 cases per 100,000.
Okay, great. I don't think that there is a major difference between the incidence and prevalence of AF in our area than the worldwide prevalence. Yeah. Also, the second question probably also Dr. Salah, someone is asking to explain quickly what is he's writing RTT. I think he means TTR.
Oh, this is an excellent question, actually. As in guidelines saying that TTR should be more than 70%. So what's TTR? We have the target INR 2 to 3. This is the target we are aiming for any patient treated with warfarin. So the aim to get this like 70% most of the time. And this can be calculated either manually or there is softwares to quickly calculate that. You know, they are available in your, some of them like using 16 days or, you know, for the last 16 days. And they sometimes saying that if the patient just initially started in warfarin, we should exclude the first 7 days. But simply, this means that patient should be in good INR at least 70% over, like, you know, 2 weeks previously to say that he's okay with warfarin. Otherwise, if he cannot maintain that, then he should be in DOAC.
Okay, one of the questions I think already you answered, Dr. Adil, is should we use DOACs in dialysis instead of warfarin as a conclusion?
Yes, I think, as I mentioned, we don't have robust data, but I think we have some you know, observational studies, some you know, real world data, and we have the FDA pharmacokinetics data. And personally, I use it in patients with interstitial disease on dialysis. But we have to estimate also the risk of bleeding. And if the risk of bleeding is very high, there is alternative, which is the appendage closure. It doesn't mean that all patients with hemodialysis, we have to give them NOACs. Some of them, their risk of bleeding is prohibitive. So in these type of cases, we might consider appendage closure. But if a patient with an acceptable risk of bleeding, I use actually both apixaban and the smaller dose of rivaroxaban.
Very good. This is a whatever you like, you or Dr. Salah can answer these questions. How many cases do you see associated with amyloidosis that require anticoagulation? And do you use DOACs in these cases?
So I may take this because I'm a heart failure guy. So yeah, amyloidosis, like hypertrophic cardiomyopathy, we give anticoagulation irrespective of SHAD-VAS score and no preference. I mean, it's better usually to give a DOAC if it is, you know, goes well with the patient. Just side point for this atrial fibrillation in patient with amyloidosis. You know, these patients will have a very low stroke volume, and we have to be very careful with beta blockers. So generally, maybe, especially in advanced amyloidosis, we may avoid beta blockers.
Comment from Dr. Adil?
I'm not quite sure what do they mean by anticoagulation in amyloid. Are they talking about, like clots or AF with amyloid? It's not clear.
He didn't specify.
Yeah. If a patient has an amyloid by itself, I don't see any role of the NOACs. As a matter of fact, I don't recall any studies in patients with cardiac amyloid. If they are talking about amyloid, cardiac amyloid and AF, then we treat it as an AF case. So we go by the CHA2DS2-VASc score, and we will see whether the patient at high risk of stroke, and we can start anticoagulation. But amyloid by itself, I don't think anybody studied that in any of the phase 3 clinical trials.
Yeah, I think he means atrial fibrillation. And as a rule, as in HOCM, we treat atrial fibrillation with anticoagulation.
Yeah.
Yeah.
Common question also, is CHA2DS2-VASc score has same value for anticoagulation for NOAC and vitamin K antagonist? So do we apply the CHA2DS2-VASc score for decision-making for anticoagulation if we are going to use NOAC or warfarin, for example?
I can take this. Frankly speaking, and I don't want to be biased in my answer, clearly the guidelines recommend using NOACs over warfarin. So year after year, I think the indications of warfarin will be much, much less and will be restricted to mechanical valve or moderately severe rheumatic mitral stenosis. Nowadays, we use NOACs because of efficacy and safety. You might actually, some physicians, they might argue about the cost issue, but still, I think the safety of the drug and the efficacy probably outweighs the cost, the marginal cost of these drugs. Now, the question is, can we use the CHA2DS2-VASc to risk stratify patients? Yes. This is the standard risk score. And if a patient requires anticoagulation based on the CHA2DS2-VASc, then he has to be anticoagulated. My preference, when the patient meets the criteria, is to start NOACs.
Great. It's clear that either CHA2DS2-VASc or has-bled are for assessment for the need for anticoagulation and the possibility of bleeding, irrespective of the medication that's going to be used. Another question is why DUACs or NOACs are contraindicated in valvular AF? For Salah?
Yeah, I think the measure, he means the rheumatic mitral stenosis. I think the initial problem start with the trials done all in US and the Western countries where they don't have much mitral stenosis case, so they were excluded from major trials, and that's why we don't have evidence that they are effective. This is the main reason, as far as I know, but I don't know if Dr. Adel has any other opinion.
No, I totally agree with you. The studies did not include rheumatic heart disease. This is one thing. And the second reason also, the huge burden of thrombus in patients with mitral stenosis.
Okay. We are approaching the end of the webinar, but a quick point here is on should we take NOAC before or after dialysis? Right.
So basically, if we look at the NOACs, the only NOAC which is dialysable is dabigatran, and the reason being because it is not much protein bound. The rivaroxaban, and apixaban, they are less protein bound, so they are more protein bound. They are not completely dialysable. So we know that dabigatran, as we explained, although it is dialysable, we don't recommend using it in patients on dialysis. So the remaining would be rivaroxaban or apixaban. And, rivaroxaban can be used either before or after, it doesn't matter because it's not dialysable. And rivaroxaban is a twice a day and also not dialysable, not completely dialysable.
Okay. Now, this question is from myself. As you saw in the introduction, I focused more on the screening methods. And you know, all of us, that the toys are too much available nowadays, from watches, and patients come with, he show you his watch and says, I have AF or I have atrial fibrillation. And there is new terminology coming up, like subclinical atrial fibrillation. And the subclinical atrial fibrillation is defined as short-lasting asymptomatic episodes of atrial fibrillation detected by whatever, either implantable devices or the screening methods that I showed on the study, the Holter, the patches, and all that. So the question is, should we anticoagulate those patients with subclinical, that they are not symptomatic, they don't have risk factors, but they had recorded episodes of irregular heart rhythms on their whatever watch, patch, device, whatever. دكتور عادل او دكتور صلاح، رايكم ايه في السبكلينيكال atrial fibrillation? Should we anticoagulate them or not?
I can start, Dr. Salah, if you don't
Yes,
mind.
please. Yeah.
So this is actually a very interesting, observation, and I will give you an example. The Apple Watch. Most people now, they have Apple Watch, and it has an algorithm to detect the atrial fibrillation, and it is designed to take a snap of 30 seconds of a rhythm strip, which is based on the guidelines. And if we look at the algorithm implemented in the Apple Watch, it came from the Apple Watch study, which recruited almost 500,000 subjects or individuals. And the sensitivity of AF detection is not 100%, but it's quite accurate in reference to the gold standard, which is Holter. Despite this, I think the message is, if a patient has AF in one of these smart watches, it does not mean that automatically he should be anticoagulated. He should have further proper investigations, because still the ECG and the Holter monitor is the gold standard for the diagnosis of atrial fibrillation. So the answer in one word, no.
Very good. Dr. Salah, ليك رأي تاني? You have another opinion?
I agree totally with Dr. Adi, yes.
Okay. Because this has been actually shown in the Artesia trial, as you know, that has been presented in the latest American Heart Association, where they showed that apixaban for the reduction of thromboembolism in patients with device-detected subclinical AF was useful and suggests a benefit to treat. That is contrary to another study. As you know, the AFNET 6, which again, for patients with atrial high rate episodes, was not useful. So these are the two latest studies on the aspect of the subclinical atrial fibrillation, or sometimes they call it high atrial episodes.
Yeah, and actually here in this study also, without going into details, Also, they mentioned part of it, AF detected by pacemakers or devices, because sometimes we detect atrial heart rate episodes in a pacemakers. So this is also what they are referring to. And it's always a controversial. Having said that, I think ultimately the decision is based also on CHA2DS2-VASc score and on the frequency of these atrial heart rate episodes. Personally, I don't anticoagulate unless the patient really has high CHA2DS2-VASc score, where I think what he recorded is real, is not just like, machine detected or
artifacts or
right. Yeah, exactly. Yeah.
Thank you very much, Dr. Adel, Dr. Salah, for this wonderful discussions. And I would like to thank Pfizer for arranging this webinar, and also the contribution of the audience for the with very nice important questions. And by this, I bring this webinar to end. Thank you very much.
Thank you very much. Thank you.
Thank you. Thank you.